the audience will come.
Okay.
Okay.
Yes.
So while Najat is not in the home, who is cooking for you?
I have someone who is cooking for me, my housewife.
Okay, great. So what did she cook for you today?
Oh, we are taking just one dinner in the night. We are taking just dinner in the night and a little breakfast. You see, I must take care of health reasons.
Okay. We always learn for you.
Yes.
Okay, great. Can you please keep this slide so we can see the address of the lecture?
Yes, this one. Cortically fixed advanced.
Yes, great. This one is fine. So people started to come in. I think they will increase by time. So where is Alexander? He's in the home with you or is it outside?
Pardon?
Where is your son? He's with you in the home or outside?
No, he's in front of me here.
Oh, great. So any help, he can help us.
Yes, he will manage me. He will manage me.
Hello, Alexander. How are you? I can see him. I think he cannot see me.
I cannot see you, but how are you?
I'm doing fine. I'm doing great. Thank you for being here for us.
No problem. Anytime. Always.
So the audience are coming now. Guys, if you can hear me very well, would you please write a note or a comment that you can hear me?
Yes.
No, this is not for you, Alexander. This is for the audience in the social media. So, Dr. Henry.
Yes.
Now the audience started to come. So I think we will start in 1 minute.
Yeah.
But I need to confirm if the voice is good for you. Would you please click OK in the comments?
Yes, the voice is good. The voice is good. It's fine.
They start to click yes. Everything is okay. So Dr. Henry, welcome to our platform. Welcome to the online education. Welcome with the cortically fixed at once approach. You are more than welcome on our board. So I would like to introduce you to our audience. Actually, I think there is no need to introduce you. Everybody knows you. So why they are all here for this? I know Dr. Henry. I knew him like how many years, Dr. Henry? 5 years or 4 years?
Yeah,
I started to follow Dr. Henry in the social media first. He was doing something very unique. Actually, the first thing attached me to him is the difficult cases he was treating. I was telling myself, oh, what is this technique? It's a very difficult technique. I cannot do it. And it's very difficult to do it. But 5 years, day by day, time by time, I discovered a very, very down-to-earth man that he can teach and he can inspire you with how to think, how to do your procedure. He's very innovative in his work. Actually, he invented a technique. Actually, it was presented before, but he modified it in a very smart way that can allow us as a surgeon and implantologist to make such a difficult case. I would introduce you, Dr. Henry. So, Dr. Henry, would you please tell us what you are doing these days in Corona time?
So, Dr. Ahmed, first, thank you very much for these kind words and this introduction. Thank you so much. And dear kind regards to all my friends and colleagues all over the world. I hope everyone stays safe and stay healthy. And I wish also for everyone a comfortable confinement. So in these difficult days, I take the opportunity to do arrangement in my house, to do a lot of lectures, because I have to read still a lot of books and other journals, as everyone I think so. So my time is passing very fast. So actually, unfortunately, we have also here in Luxembourg a lot of cases and death tolls. That is unfortunately not so good, but we are hoping that the situation that we will manage the situation.
Please keep safe. We need you.
Thank you.
Implantologist needs you, so please stay at home and keep safe. So, what are you optimistic about the I would say the world after Corona? I mean, now we have world before Corona and world after Corona. So
yeah, I think for sure the world will be a different one, and hopefully.
It's good or bad?
Pardon?
It's a good or bad? Different means it's from your point of view.
Yeah, it's a different one. The point is just if our human beings will understand how to behave, and especially for our politicians, that they understand that they have to invest in health. Because actually, especially also here in Europe, when you look in countries like Italy, like Spain, or like UK, where investment in health policy is very bad. So there's no budget. And that is a very big problem. So I think it is important that you invest in health workers, in doctors, and that you support them, because you see, it just have to happen once. And that is what is going on now. And then I think really humankind must change also in the behavior and what we will do in the future. Hopefully we understand the lesson.
Yes, and the hard way. We understand the lesson in the hard way.
Yes, absolutely. Because actually we don't know when it will be finished and what will be the outcome. So that is very difficult. That's very difficult to know. And I think actually nobody knows.
Exactly. The outcome is not really it. So, Dr. Henry, let me ask you about something. Many people are considering you as a role model. So
sorry, I didn't understand.
Many people in our dental community, they considered you as a role model for them.
Okay.
You are like a role model for them. So if there is any advice you would like to give to them?
Oh, yes. I think that is it's very easy. First, you must be excited about what you are doing. You must enjoy. So that is the first most important thing. And then lifelong learning. Because still actually at my days, each day I find out that I don't know so much. So I have to learn, and I have to learn. But to do this, you must be excited to do it. And once you're excited, there's no limits. And that is the key of success.
Yes, sure. So Dr. Henry, another question. What did you do something while you were young you feel it makes a difference for you while you are becoming a professional dentist?
Yet I think what was a very big mark in my life was that I was since young years at 16. At 16, I became the youngest football referee here in Luxembourg at that time.
Great.
And being a referee, because later on I became a FIFA referee, so international referee. I learned so much because you see, once you are a ref, you are just alone, and that is also in our profession. Once you are doing a mistake or once something is going wrong with your patient, you are just alone and you have to manage it and you have to see the outcome. So that is something I learned. I learned in this all the years. I was 25 years a referee with very interesting matches. So, and that was for my professional career. That was a very big asset to give me all the hope and the success which actually I have in my profession.
So let me conclude this. So you are advise young dentists to be a football players?
No, I advise young dentists.
I'm just kidding, Mr. Henry.
That could be a little different. No, I advise dentists to be active, to do sport, to have some sport activity. First, to protect your back, because actually nowadays each morning 6 o'clock I go for my jogging. So that is
great. We wish we all are doing this. We wish.
Yeah. So that is my first exercise in the morning. I go out, I run out, I take fresh air, and then I may go to my clinic and I work 12 hours. So that is the energy you have, and sports give you all the energy and all the good moods that you need.
Great. That's a very Great step. So what
and for this it's no age. And for this is no age. So younger you begin, better it is.
Yes, thank you for this advice. So Dr. Henry, you told me you were surprised me with a lecture today. What I mean, many people they are trying to reach you. Many people they cannot travel actually in the last 4 years. They followed you on the social media, and this is the real first time they can see you. They can see your cases. They can see what you are doing. So please surprise me with the recipe, a new recipe.
Thank you so much. Thank you so much, Dr. Ahmed. So I think I will go on with the presentation. So there will be some theoretical part, but little part, and then I show the cases, because I think the most interesting part is to see the cases, to see what is possible. And then the other part which I want to say is, you see, also cortically fixed, it is another tool which we have in our daily practice to see and to help our patients. Because you see, more tools we have, better it is, and more efficient we are, and more patients are satisfied. So that is my message. And then let's start and let's see and let's enjoy.
Let's enjoy. Let's go.
Thank you. Let's go. So now here, I think that is in the meanwhile something everybody knows about COVID-19. Before some weeks, nobody knew about it. We have some special pics here from Paris. You see, Eiffel. That is Eiffel tour. Nobody is there. I think that is unique pictures, or like here the Champs-Élysées, never seen before. I think we will get things.
It's empty. For the first time, nobody there.
It's absolutely empty. And then, as we spoke about refugees, that was in my younger years, in 86.
Okay.
That a pick from there. Here I was a referee in the cup final in 1995. Another pick about my career as a FIFA referee. So I spent a lot of hours. On the beach. So it was quite interesting. So let's come to the topic. So immediate loading in the atrophied bone using the cortically fixed advanced approach. So that's a brand, CFO. Here, that was the team on which we worked in 2014-15 to build up. You see also on this pic Dr. El Moheb and my friend from Brazil, Alex Marquez. And there's also Dr. Dainius. Dr. Dainius is on this pic, and Sergey from Trade Company. So that was a meeting in Luxembourg.
Sergey, he was young. Look at him. Yeah. Sergey, he was very young.
Yeah.
I should motivate him with this picture now.
Yes, absolutely. So now you must know the objectives. The main objective of cortically fixed at once is the restoration of vital function and characteristics in difficult and extremely difficult anatomic situations using a minimal invasive procedure. And a root form implantology only approach, for example, may require prior modification to the bone anatomy using grafting procedures before implant placement is feasible. And cortically fixed at once enlarge the scope of implant dentistry without requiring recourse to complex techniques such as distraction, bone splitting, grafting, etc. prior to implant installation. Principles. So no superstructure can be more enduring than its foundation. Occlusal stress and foundation resistance are reciprocal forces, which must be properly balanced to obtain durable functional efficacy. And the long-term function of cortically fixed implants requires establishment of an active bond between the tissues and the implant. And thanks to an osteoadaptive process, the multicortical implants are incorporated in the hard and soft tissues, which gradually adapt to their new functions through the remodeling process. Creation and maintenance of the structural and functional bond between biological and non-biological materials mandate precision, stage of treatment, plus the respect of basic principles. So if you see now, let's see the bone. We have different characteristics of cases. We have the available bone at division A. So here bone is sufficient for root form implants. It's quite easy. But then here, division B, bone density is also an important fact. So we have bone height and bone density. So bone density, we must play on it. And then we have the division C. And then you see there is no more bone or not enough bone. And then hybrid plates in the maxilla and the mandible are indicated. And then in division D, that is the most challenging part. The bone density, we have these different classifications, which everyone know, Karmish and Lenko and the resorption. And then this is maybe not so known, is the Cavut classification, where we see the height in the posterior maxilla and mandible, as well as the anterior part of maxilla and mandible. So then, when there's no bone, what to do? So we may adjust anatomy with the different techniques and bone grafting as we saw, or we do in the mandible nerve displacement. We may, for instance, do a bone harvesting from the skull. So that is from my colleague in Brussels at the University Hospital in Brussels, who are doing harvesting by the skull. And here we may see a little bit how it works. So of course, that is, I think, that is a very nice technique. I think that is one of the gold standards also to harvest bone. And of course, sometimes we have also, yes, to do relaxing moments in our profession, to take some fresh air.
Yes,
and
we
then,
have to.
Yeah. And then, beside adjusting bone anatomy, we may adjust implants. We have zygomatic implants, we have all-on-4, we have trefoil from Nobel Biocare, or we have CAD-CAM solutions actually. And now we may add also cortically fixed advance, which you see on our right pics. So what is the specificity about cortically fixed? We have specific implants, which are hybrid plates, which give us a primary stability. We will achieve an immediate loading. It will be minimal invasive, and we may avoid bone augmentation. And I think that are elements which are not to underestimate, specific for us in our daily practice, and then for the practitioner and for the patients. So let's see how it works. So what we are using in the cortically fixed, as the name already, or the brand already is telling us, we are looking for the cortical areas of the skull. So you see the zygomatic bone, you see the premaxillary, and last but not least, the pterygoid plate. All this region, which are the fourth lines of our skull, are delivering cortical bone, and we are using this bone to fix our plates, which you see here. The plates in place, you see, fixed at the premaxilla, at the retromolar region of the mandible, and at the zygomatic arch, fixed with osteosynthesis screws. Another time, repeating here, the vertical pillars, you see the compact bone of the face, and then our plates. So we have 4 plates in all. Here is Hank 1, which is a patented, which means highly efficient, no graft gear. You have a Hank 2 plate, you have a Hank 3 plate, and a Hank 4 plate, which also patented. And all these 4 different plates, they are specific because you have specific indications for these different plates. And then here you see a full maxilla with the plates. Also, a specificity of the plates is that they are flexible, halfly flexible, because you see the plate, they are all delivered in one shape, and then they are bended and they are adapted to the bone. They are fixed with screws. We have screws with surface treatment or without treatment, and also the plates are treated with hydroxyapatite and tricalcium phosphate, which gives us a special attachment to the bone. And then here, that is the special, the trick, let's say, the trick or the specificity of the plates. There must be a special bed has to be prepared in the bone to receive the plate to guarantee this primary stability, and we hope and we want, and which happens also, that the bone will grow over these plates, that we become, and that is also very specific, to get an osseointegration of the plates. Here you see those different plates. You see the bed which is prepared. Here I did a research work. We did a finite element study about the biomechanical behavior of the plates at the Rey Juan Carlos University in Madrid with Professor Juan Carlos Prados Frutas. There's a scientific publication which is done. Just to see, so
Yes.
Now I think the principles. So
Exactly.
important is that the long-term function of these cortically fixed implants requires an establishment, an active bond between the tissues and the implant. And thanks to an osteoadaptive process, the multicortical implants are incorporated in the hard and soft tissues, which gradually adapt to their new function through the remodeling process. So the principles are guided by a multicortical implant support. As already told, we have anchorage in the major cortical bone pillar of the jaws, which has a zygomatic process, the pterygoid plate, the canine pillar, vestibular and buccal corticals, and torus nasalis, and an absolute primary implant stability in a dense living bone by using specific implants. And here, fortunately, I have this all these type of implants, which are root implants, which I may combine with these plates. Here we have the specificity of these pterygoid implants, which are also a special design and have efficiency. And in this protocol about all the stabilization, we need to stabilize our plates by a posterior anchorage, which is done by the pterygoid implants, which is very essential. You see here our pterygoid implants with the preferred position is the medial wall of the pterygoid plate, which you have a very, very strong anchorage, and here position of the implant. Sometimes you may have also this position. And then to show you the plates, how they are delivered. And now, of course, it needs a learning curve. You must be trained in the technique, because receiving a plate just like this and trying to fix it without a specific training, without knowing the principles, is impossible. It's impossible because you must be trained. I think also in normal implantology, if you are putting when you are learning implantology, you also get trained, and also you must know the principles, and here it is the same. So you see different options. So the plates, they may be used as well in the maxilla, as well in the mandible. We may use them for total rehabilitation or for partial rehabilitation. So you see here just the pics with different options. Here you see, in general, these are big atrophied maxillas when you're putting 4 plates. And of course, if we may put a supplementary 1-piece or 2-piece implants between the plates, that is, of course, a big advantage.
Great. Yes.
You see here these different options, different possibilities. Yes, that is a nice case. You see, we have just bone atrophy in the posterior area, and then we are putting implants in the front. We are putting the plates, and we are putting clearwood implants, and in a very fast and in easy way, we may do full rehabilitation. Or here is a specific hang 4, because the problem with the bone is the density. Because more anchorage points you have to fix a plate, better it is. Because yes, here you see on a plate you see four screws, but sometimes it is just possible to put 2 screws and not more. So that is very mandatory, and you never know, which may happen. Or here, it was just possible to put 4 plates and nothing else. So, but the anchorage, the posterior anchorage, is done by the clearwood implants, and we are here in a safe situation. So let's see now some cases how we may manage it. So here, for instance, this lady was 57, and I did this case in 2012. And then you see here, and that is also the advice I give to begin.
Printed model? Huh?
Yes, they are your printed model. So for beginners to try to the printed model or to see the case, or first to see the case, maybe you adapt the plates also on the model. That is a little bit individual, but a printed model is a big help to see the anatomy in reality. So here was the process with the patient, but she wanted fixed teeth, and the final end was this metal ceramic bridge. So here the surgery was done on the local anesthetics, and then was a protocol. We put clearwood implants, we put the plates, and that is a control 2017, 2019. So nothing happened, and yes, it was. So what is now extremely interesting? We have one surgery, and in general, the patient is finished after 10 days or 12 days. That is just great.
I got you. So let me ask you something about the previous case, Dr. Henry. For how many dentists did she went to ask for treatment, and what was the proposed treatment plan?
Yeah. She went to a lot of dentists, and all dentists did proposal of bone grafting and taking time. So here also the next case I show you here, because this lady is also 54, and you see the big atrophy. The big atrophy here. Look on the.
It needs sinus lift. It needs augmentation.
Yeah. And she was scared about it, and she did not. Because it takes time also, and it may be painful or not. Now our friend Dr. Frank Zastrov, I listened to his great presentation. All my compliments to him. So of course that is the other issue. I think it is. Now, let's say we have to deal with different type of patients. The psychology of the patient is important. Time management is important, and then yes, and the technique. So I think it may be sometimes one man likes this car or this car. I think it is very, very, very different. Huh? So, but the advantage in this technique is. When we have a failure, you see, when we have a failure, look this case here. Let's just go on here. We are preparing the plate. We are adapting the plate. You see, the plate is done here in place. I covered it with membranes and with done. The impression is done immediately after the impression is done after surgery. We are putting a temporary, and here the finished bridge was settled 10 days later, and that's the case. So. Here, 10 days later, the lady was finished. And of course, she was very happy. But now you see, we must always think that these cases are very tricky cases. And, what may be the come out? What may be the failure? Of course, sometimes I have failure. I have to remove a plate. But by removing a plate, there's no damage I do. So it's very easy. When I put a zygomatic implants or more zygomatic implants, and we have infections and we have to remove it, for the patient, it is a huge issue. And then another time, all the cases are done on the local anesthetics. So it is, for this, I allow to say it is minimal invasive if I compare it to other techniques.
Yes, you're right. So in how many days, Dr. Henry, did she load?
Yeah, after 10 days. After 10 days.
10 days.
Yeah, maybe 10 days.
Great achievement, yes.
Yeah, it is depending a little bit also from the lab, how fast the lab may work. So that is
and how much efficient the lab.
Yes, and how efficient is the lab. Nowadays, the lab, because this is depending on the countries now, the lab may work still by casting or by CAD/CAM. So actually, I work with CAD/CAM with my lab, but it must be very precise. Casting is a little bit easier. I think it is a little bit easier because before I worked with casting models, and it was a little bit more easier to handle. By CAD/CAM, it must be really, really very precise. Otherwise, it will not work because you see here the bridge is entirely screwed. And then also that is the advantage. If there is a problem, I may screw it out, and the handling if the complications are quite easy. Then here you see teleradiography. You see the pterygoid implants. You see the pterygoid implants, which gives you the strong cortical anchorage. Oh, here, and then you see also what is very specific here. I deal with patients, let's say, from young to old. And also this patient, 79. So one of the last pleasures at 79. So the manuscript...
She will not withstand the severe surgery or aggressive surgery.
Yeah, so what is now severe surgery? You see, 79, the guy, he's so happy, he's in good health, but he cannot eat because he's wearing a total prosthesis, and this prosthesis is falling out of the mouth. So he's very unhappy. So then, of course, you see, when you may suggest a surgery, a one-step surgery, that is the important point. You're doing a one-step surgery, and 10 days later, this patient have another time life quality. He's excited. So you see, bone augmentation, sinus lifts, etc. at this age, yeah, you see, we always want to avoid heavy surgery and complication and infections to patients at a certain age. But here also you see, here it took 2 weeks, and 2 weeks later the patient was done, and he had, you see here, you have the metal frame. We tried in the metal frame, and then here we did the metal acrylic bridge. That is a question of price. Metal acrylic is not so expensive because from the lab costs. And then you see, 10 days later, the man had this in mouth, and he was happy. Life quality in a very short time. Or here,
would you please, Dr. Henry, send my compliment to your dental lab?
Oh, thank you.
It should be. He's a talented guy.
He will appreciate. Thank you. Thank you so much. And then here you see another case. Also, this patient, I just have here now just the panoramic, but the ridge. The ridge was very thin. There was no width. So he wanted fixed in the maxilla. Here you see here the ridge. It was very thin. And you see, I put here these compressive implants, compressive M implants. I put them behind the ridge. I put the plate, and I do the placement, and I put the placement 10 days later. So here's this metal frame, and then here also everything was screwed, and yes, the patient was very happy.
I can see, Dr. Henry, in every case you just put 2 pterygoid implants each time. Is it mandatory in all of your cases?
That is the good advice I give. You see, especially when I train colleagues and doctors, I want to give them security. And because sometimes, unfortunately, it happens also, but in very few cases, that there is absolutely impossible to put a pterygoid implant because there's no bone anymore. So then, yes, sometimes it's not possible. Then, of course, I don't have no choice. I have some cases without a pterygoid implant. So I have to see the long term now. I have to see the long term. You see, I have long-term results. I have long-term results with pterygoid implants over 18 years with total bridges. So I know the efficiency about the pterygoid implants. So that is the point. Is it mandatory? So I think I have big responsibility when I teach something. I want to give security to my colleagues. So and then I think you may become good by learning by doing. You have to do it.
Yes, yes, you are right about this one. Yes.
And also here, that is another case. You see here, I could combine plates with one-piece implants or with compressive M implants. So I combined here cementing and screwing.
We have some question, Dr. Henry. Do you want me to tell you the question now, or you want it at the end of the lecture?
No, go on.
Dr. Hussam is asking, what is the impression technique did you use in the previous cases?
The impression technique.
Yes.
We will see it. Huh?
Great.
Impression technique will come. I will go on with the cases.
Okay. And there is another question regarding the bending of the plates. It says there is any internal stresses in this bending, or it will come back again, or it's just the deformation will happen.
No. You may in general, you see, there is no problem with the bending. So you may bend and rebend.
Okay. And what about the temporization? You are telling us 10 days or 2 weeks. So what you are doing regarding temporization here?
Yeah, we are doing a temporary bridge.
Temporary bridge, the same day of the surgery or after 2 weeks?
No. We are doing immediately. We are installing immediately temporal bridge because very often people are wearing still an old prosthesis, and so we are doing like in the old we are doing like we are doing an impression of the prosthesis, and we are taking this to put to do the temporal bridge on the abutments after. So we have special pins to put on the plates to put the temporal bridge.
Okay, thank you. Okay.
So to check this now for the atrophic maxilla. So the limits of the maxillary sinus buccal landmark are easily identified because cortically fixed implantology is a full flap procedure. And the atraumatic elevation of the periosteum by gently separating the tissues using a gauze pad avoids injury of the inner layer of the periosteum and inadvertent penetration of the sinus through the fragile eggshell thin lateral wall. Where applicable, the infraorbital foramen must be exposed. The infraorbital nerve remains in the full thickness buccal flap. And sharp crestal soft tissue incisions should be made until the scalpel reaches the bone crest. In the tuberopterygoid area, full thickness buccal and palatal mucoperiosteal flaps are elevated using the same approach, and major minor palatal arteries must remain in the full thickness palatal flap, and this will be obtained by remaining in close contact with the palatal bone during flap elevation. So that is a little bit explication about the surgery. So here
we have a question regarding the flap, Dr. Henry. The question, I think it's time to say it, they are talking about the blood supply. From your point of view, if you are going to open this amount of flap, the blood supply deficiency in this flap will affect the osseointegration or not?
No. So it is important to know. When doing the flap. First, we are doing the flap with one side only, and then we are finishing one side. We are doing the stitches, and then we are going on the other side. We are not open all the maxilla in one time, because more the flap is opened, of course, more the wound become acid, and of course that is not good.
Okay,
that's for clear. Okay.
Okay, I'm with you.
So here you see the cases we see. This lady, she's 60, and she comes also with a broken bridge. So you see here the thin bone also. That was the situation in mouse. So yes, she was very unhappy. And then here you see on the left side, you see another time the ridge, how thin the wall was. And then, of course, you see we are beginning with a pterygoid implant. Pterygoid implant is in place. And here's the plate. We are adjusting. Look here on the right side, the plate, how it is fixed also in the palate. You see, you see there's a cross. You see the specificity of this plate is a cross in the palate to avoid also mesiodistal movements. So that is very unique. And then you see also the bed, which is created in here, the maxilla bone to fix it, and then the osteosynthesis screws. And then on the left side, you see the bending, how you may bend.
Oh, this is very smart. Yes.
Of course, you see the bending technique. You learn this in the training. You are taught how to bend this. And then here you see we are fixing we are preparing hang 4, and here another side you see the bed which is prepared, and then it is covered around. It is covered around with bone grafting material and covered with bone grafting material. And then here we did it, let's say we did immediate loading in the way that in the front we did extractions, and we put 2-piece implants. We did a temporal bridge, and then in the secondary step we took here the impressions for the definitive bridge. And here you see we did by open transfer the impression. We did the solidation with the luxabite. We did here try-in. After we did the try-in with pattern resin to be sure, and we took another double impression over the try-in to be sure that everything would be perfect. The soft tissue management, you see on the left, you see how it's the plates. On the model, you see what was our situation. So first we tried in with resin, and then another time with metal. You see that was work in progress. So here I combined 2-piece root implants with plates, and then with pterygoid implants. The plates were there where no bone was present, and that was the day of the placement. The finished metal ceramic bridges. And then this was done by delayed loading because the patient, she wanted to have special aesthetics and so on and so on. So here I did it by delayed loading. You see here, I could also splint here the bridge as it was delayed. When I do an immediate loading, I have to splint the bridge. The bridge has to be in one piece. And then here was the final work. We did also the mandible. We did crowns in the mandible. And that was then the finished case of this. Or here, another time, you see, the problem is we may offer different treatment options to the patient. And here you see also this lady, she came, and how often I think this happens to all our colleagues. She's 70, she had an old bridge. You see what is still remaining in mouth, some roots, we take it out. And then was 10 days after the surgery. So here it was a very easygoing case. We took out the teeth, we put in 1-piece implants, the plates, the pterygoid, and yes, 10 days later, the lady had a new smile again. I think that is absolutely excitement for the patient and excitement for the practitioner. So, and then you see, and I always just want to say it is a treatment option, but believe me, you give happiness to the patient.
Yes, you are right. So here a question, Dr. Henry. How do you analyze number of plates per patient? I can see sometimes you put in the anterior plates, you put compressive, you put root form, you put 4 plates at the maxilla and 2 pterygoids. So if there is an equation to analyze how many plates we can put and how many implants, or just it's by experience?
No. You are always guided. by either by your scanner, of course, by your scan, and by your panoramic. So we have to decide on the bone disponibility, and it is evident. You see, if you have a lot of bone, if you have a lot of bone disponibilities, you put 1 piece, 2 piece implants. That is not the question. Plates are only put when there's no bone.
Okay. It's
So
very
that
simple,
is-
yes.
Yeah,
So
yeah,
four plates are enough in the full arch if we don't have any kind of bone?
yes, but with pterygoid implants, yes.
Pterygoid implants, okay.
Yeah, but anyway, you cannot put more. You cannot put more.
Okay,
cannot
I got
put
your
more,
I got your point.
so
So
because-
let's make this equation. If you have a bad bone, and so the minimum is 4 plates plus 2 pterygoid,
yes,
or 2 pterygoid, 2 plates, 4 anterior.
yes. But very simple rule: the bone is your guide.
Great, yes, totally understood.
Because sometimes you see, even if you are in the bone, if you are in the surgery, you see there is bone. Initially, you see the bone, but maybe you don't see. But maybe you don't see or you don't know the bone quality. And
Exactly.
this you may only see it when you are in the surgery. And then yes, you may switch. You have to switch because screws impossible to put it because it will not remain in the bone, and then you have to switch on a plate. So yes, that sometimes may happen. So that is then another advice, of course, when you're in the surgery or before going to surgery, you must have some disponibility of plates because maybe you are going for 2 plates and at the end you need 3 plates. So it's better to have 1 plate more.
Okay.
So and here also after 1 year, and also here all these surgeries in general, they are without any complications, and that's also which is quite it's fantastic. So myself, for all the surgeries I did, I'm always excited because excited by giving life quality in a very short time to my patient. Look, this patient, she was very unhappy. She was treated for a long time, delayed loading. She becomes these implants. And then the doctor told her, yes, you will get fixed teeth. Yes, but fixed teeth for the doctor were a prosthesis which was fixed on the implants, but removable. So the understanding to the patient was not good, and she was very unhappy. And then you see there was no bone, but the colleague, he could not do nothing else because he was not trained in sinus lift or bone grafting. Okay, then he sent it to me. And you can imagine what we did in the case here. So we put the plates in place. I use transfer of these implants. And then you see 10 days later, this case was done. So, and the lady was very happy because I could solve the case and the situation in a very short time, thanks to the plates and thanks to the pterygoid implants.
Yes.
Treatment option.
And thanks to you.
Pardon?
And thank to you.
Yeah, thank you.
I have a question, Dr. Henry. The plates, do you drill it, or it's just self-tapping?
What's
the screw in the plates?
The screws, yes, they are self-tapping. They're self-tapping.
Self-tapping.
Yeah,
okay.
Self-tapping screws, special.
And we have a question regarding the failure. If there is a failed plate, how many months do you wait till you make another one?
That is depending on the case. Maybe you may do it immediately. That is depending on that. Maybe depending on the failure. For instance, you may have there are different options. You may have a mobility of the plate. And when mobility of the plate happens, then you will get tissue under the plate. And then, of course, it becomes, it's not so painful, but it is annoying for the patient. And then, of course, you take out the plate, you take out the tissue, and immediately in the same session, you may put another plate. But sometimes, if there is dehiscence of the gum, so it maybe also happens that you have dehiscence around the plate, and then it's depending about this dehiscence, but then it is not so good because now first dehiscence may be without any problem, no problem at all, but maybe also that it may be a reason of infection or uncomfort or discomfort for the patient. Then, of course, in this case, you have to take out the plate. You take out the plate and you do stitching, and then you wait the healing, and then after 3 months, 4 months, you put another plate. So all this is that is case depending. That is case depending.
Okay. What about if the I mean, did it happen with you before that the screw perforate the maxillary?
Yes,
Sinus?
you are going. Yes, of course, you are going with the screw in the maxilla, but for this you need to take these untreated screws. Because also in maxillofacial surgery, you are sometimes entering with the screws.
Yes.
You're entering with the screws to the side.
Like zygomatic implants. It's totally, yes, you're right.
Yeah. No. So it is in general that is without any problem.
Okay.
Now, in general, and also what I want to say that is about complications. There are very, very, very few complications about all what may happen. Okay, we may go on.
Yes, we can.
So here, that is another case. So also this lady, she's 73 years old. She wanted to change her smile, so it was difficult case to see. So because another time she wanted to keep her diastema, so that was a little bit challenging part. But then, yes, you see.
Yes, you keep the diastema. That's good.
Now, so we kept it, and yes, we did the surgery in one step, maxilla and mandible, and that was the result. So, and here also I used one-piece implants. So the advantage by doing a case like this, and especially also for the one-piece implants, you may do it very fast. That is one of the big advantages by this. And you see sometimes patients, once surgery done, they're a little bit reluctant to do a second surgery, especially by these cases. So very often when the indication is done, I do maxilla and mandible in one shoot. And also another time on the local anesthesia. And also here there was no complications in the follow-up. And here, atrophied mandible, you see that is a very difficult case.
Now, this is very difficult. We have to do vertical augmentation.
Yes.
And we have to wait many months till the bone is hardened. Then we can go with the implant. So what was your treatment here?
You may imagine. So here, that is a situation in the mouth. We are preparing here, you see.
Yes.
On the right side, you see we are preparing the bed for the plate. And that is very, very unique. You know? And you see the bending of the plate. And here, you see this like, we are doing a slice. We are doing a slice. And we are putting the implant in the bone. To get, why? But to get, first, primary stability. But on the second step, the bone will go over the plate. And by this, we are doing osseointegration. So it is the hybrid plates are not a superior still implant, and they are put in the way to become osseointegrated. And that you will see. And then also this difficult case, you see the bridge was already finished after 10 days, and here was the day of the placement and happy patient. Here it was done in 2014, 2017, and then the maxilla was done also.
Oh, she liked the game.
Yeah. So that is huge.
This is life changing. Yes.
Yes, life changing. And you see what happened here. That I opened to patient because there was some problem. But when I speak about osseointegration, about the plate, look what is happening here. The bone is
over the plates.
That's amazing. So that's really amazing. And that is what I always see, you must see to believe it. But the bone is growing over the plate and you are getting an osseointegration of the plate. And also in the maxilla, you see also here, bone is growing over the plate. Why? Because the thickness, if the plate is just 0.6, and that is enough that the osteoblast may jump on the plate and do an osseointegration. I think that are very unique. That are very unique pics that like this you don't see in the books. So then, when we are doing an atrophic mandible, we had two critical anatomic elements which must be considered: the lingual nerve and the mandibular nerve. And you're doing a sharp crystal incision, which are doing in the middle of the remaining attached gingiva. And also here the scalpel must be in contact with the bony crest. And the full thickness flap must be elevated from the lingual side first, always keeping close contact with the bony wall. And also the gauze separation technique is recommended to avoid damaging the periosteomomandibular nerve. And this technique also eliminates the risk of injuring the lingual nerve because the structure remains inside the lingual flap. The procedure is then repeated from the buccal aspect in order to identify the mental foramen. So it is quite tricky. It's quite tricky. The atrophied mandible is quite difficult. And then you see we may do unilateral or bilateral edentalism, like here, that is done in 2012 on the left maxilla side. We are doing extraction, implantation, frame, and then it was a finished case. So one surgery and the case was done. And here another time you see the situation of the plate. Or here's a lady. She had a broken bridge in the right maxilla. Bone quality was bad. And here you see we are using a pterygoid implant plate, which is fixed, the bridge, and then 10 days later we fix it. But here you see, and that's quite interesting, these pterygoid implants, these root implants, these compressive MP, you may use them also in extraction sockets. You see here in position 13 and 14, I use them, and they are very, very useful in extraction sockets. And also when you have a bone of bad quality. Or here, you see that are also very tricky situations when you have to replace this missing tooth on both sides. Here you see the implant is done and integrated in the bone. And then that was the result. Then already 10 days later, immediate loading, and all over the years. That is now 6 years old, the case, and no complaints. But that is always difficult. Now here, that is young lady, 45. You see here on the right side, there was also a huge sinus. And here we had to put hang for. So another time, as I said, you are guided by the bone. Here I had to use two hang for plates, and the result was this. Here we may also use it in the mandible, a plate, and then with one-piece implants, and the result was immediately. And then here you see the maxilla, the mandible. I did the mandible already. I did the mandible 8 years before by immediate loading, and use the maxilla. The maxilla is difficult, so I think by classical procedure, you know what you do. To do by cortically fixed. Also, sometimes you must decide immediate loading or delayed loading. You see, the left side could be done by immediate loading because there was enough bone to fix it. And another time you see I used a pterygoid implant in the extraction sockets of the canine and the pterygoid implant, but on the right side, I just could do delayed loading because there was not enough bone to support an immediate loading procedure. And here I put the two-piece implant, and then you see by delayed loading, I put the metal ceramic bridge. But I could avoid it all other procedure. Or here it was the same. You see I had the right situation on the right side. The bridge was fallen out. And here I did extraction and did the implantation. And then the finished case, it was 4 months later. So the hybrid plates, they must be installed with a multi-cortical anchorage because absolute primary stability is essential to obtain osseointegration that is maintained over time. And the design and the dimensions must permit the connection of the prosthetic components in a functional and useful manner to create a fixed prosthesis. And the occlusal forces transmitted via the future prosthesis must be properly distributed as not to exceed the breaking point of the bone and the prosthetic components. And then we have loading protocols, so that is technique and maintenance and follow-ups. And then some general considerations. So post-operative occlusal stability must be guaranteed during function by means of a fixed, rigidly splinted implant prosthesis. And this rigid appliance serves as a purpose similar to external fixation in orthopedic surgery. It protects the implants from micro-movements during the osseointegration process, thereby facilitating bone reconstruction while preventing displacement, and allows the patient to rapidly return to a normal lifestyle. So, anticipation of potential problems is also an important factor for the long-term success of cortically fixed restorations. And the knowledge and the experience needed to satisfy these requirements cannot be improvised, nor can then be acquired without appropriate theoretical and practical training. So if colleagues are interested to do some training, I think they may contact you, or they may send an email to info@corticallyfixed.com. They may also have a look at the webpage, corticallyfixed.com. And thank you very much for your kind attention.
Dr. Henry, we should thank you for this lecture. Now, can you see me?
Yes, I see you. I have to go out. I have to go out.
No. Can you see me now? You have
I
to
see
go
you.
out of the presentation.
Yes, I go out of the presentation. One moment.
Yes, exactly.
One moment. Yes, I see you now. Yes, fine.
Perfect. There is a lot of questions, and first of all, I would like to thank you for this great lecture. Many people, they were seeing your post in the social media, and they were having a lot of questions. But I think many questions were answered in this lecture. Actually, there is a lot of challenges. Regarding this technique. I mean, when you need to compare between this technique and, for example, the printed plates that's coming now. So, can you tell us what the difference between this ready-made plate and the printed plates, and why do you prefer this technique for your cases?
Now, I think we must be always open-minded.
Yes,
also,
sure.
Also now, colleagues which are doing the printed implants, like they are showing cases, which is big reconstructions. Yes, of course, I think it will be a very interesting alternative. I think this tool, what we have here, is still a tool which allow to a greater public of practitioners. You see, basically, my training was as a dentist, so I was not trained as a maxillofacial. So okay. If we are doing this technique, by having the knowledge and having the technique, it is available for more practitioners. And then the point is, actually, because I have some discussions with my colleagues who are doing these big reconstructions with printed implants. You see, here another time, when I have a problem, it is easy to take out and it's easy to manage. And it's also a question of price, because you see, buying an implant like this, the price involved is different. Is different like the printing implants. So I think it is another time. It is case selection, patient selection, and then practitioners. Practitioners, you must be trained in the techniques, and yes. You must see which colleagues will have the ability to manage the 3D printing implant. So we will see. We will see. I have now follow up over 8 years. So I may say which works and which will fail. So in my technique, and that is already a long-term success. And anyway, the problem also with the printed implants, the big challenge is always the soft tissue management.
Okay, I have another question here. If you are working in the mandible, you will screw the screw, or you will drill for it. The mandible, the bone is very hard.
I will just open the bone with a drill. I will just do a little pick to the bone, just to open the bone, and then we are self-tapping. We are self-tapping.
We have a very important question here. How can you deal with diversity and unparalleled implant placement? Now you are following the bone in this case. So at some point you should make it all together parallel. So what's your technique to make them parallel?
Thank you. That is very interesting. That's a very interesting point. And another time, first, you are guided by the bone. And the technique you must understand is when you install your plates and you must install your implants, you must always check to be parallel. You must check. And that is difficult in the beginning, especially also when you put the plates, because in the beginning you are so stressed to put the plate, but then maybe the abutment is too much buckle or too much lingual. Then we have a big problem. So it is a learning curve, and you as a master of your result.
Yes, a very wise answer. Yes. So we have here another question, a very important question actually. How do you deal with the bone resorption after the extraction?
Yes, interesting. So in general, when I so there are different considerations. When we are putting the implants immediately in the extraction sockets, then of course we don't have so much bone resorption. In general, I go immediately for metal ceramic bridge. In general, because I give good stability for my patient and safety for my patient. But that means if there will be gum retraction over time, maybe after 6-8 months, yes, then we have to do double impression. We have to take out the bridge, and that is important that everything is screwed. Or when it is cemented with temporary cement. But we are taking out the bridge, we are taking out the ceramics, and we are doing a double impression on the frame, and we give it back to the lab, and then we put it in the mouth another time. So that is safety. Of course, you may also go with a temporary bridge. Yes, but the problem is with the temporary bridge, after you have to take another time impressions for the definitive bridge, and so on and so on. It is more easy and more faster to go by metal ceramic immediately. That's my experience.
Okay, we have a very important question. Actually, the question is, from your point of view, what are the main reasons for failures for such technique?
Case indication, and not trained practitioner.
Yes, very wise answers. It's a case present. Okay.
Case indication, especially because you see, also here. Also here, you cannot treat all atrophies with the plates. Impossible. But because now actually I have colleagues who send me X-rays here. Doctor, please send me the plates. I have a case here. I want to put the plates. But then I see the scan, and there is even no bone in the palate. So if there's no bone, you cannot fix the plate. So also the plates have limitations. And when and sometimes, yes, I also have to say no to my patient because I don't want to damage my patient.
Very wise answers. Thank you, Dr. Henry. I know it's very late for you now, and I wish the discussion it can extend to 2, 3, 4 hours, but let's enjoy this time. I appreciate your appearance here with us. I appreciate your value time. Many of your audience and your students and your followers, they feel happy to see you and see your lecture. We wish you a safe night, not a good night anymore, and we wish you come back again to your physical lecture to see you again. And
thank you. Thank you very much for this invitation to have the opportunity to give this lecture, and also for you, Dr. Ahmed, a fruitful confinement. and hope to see you very fast in live again.
Okay. Thank you, Dr. Henry. Have a good day.
Thank you so much.
Goodbye. Goodbye.